Great, okay. I'm Rich Lord. I'm Chair of Family and Community Medicine at Wake Forest and at the med school, and also Vice President for our population health. And so this has been, for me, an interest just because I'm training residents over the past several years, and with enough gray hair, I've lived sort of through, as many of us have, the era of in residency, we started getting beat up that we're not treating pain, not treating pain. We've lived through the pain is the fifth vital sign, all this stuff, and we were told we need to be treating more and more. And now what I'm hearing, at least from some of our residents, is I'm never writing this stuff, right? And that's sort of what I started to hear a couple of years ago and started to become concerning on that. At Wake Forest, our tagline for the medical school says, Wake Forest, a mission to care, a mission to cure. As we just heard for some of the folks, if they have addiction, we're not necessarily curing them, we're going to care for them. And the same thing for folks with chronic pain, to say, I'm never going to do something. There's very few nevers. I guess you never should take out the kidney when it doesn't need to be taken out. But a lot of what we're working with our patients is going to come from there. And so I hope this morning with walking through this, it'll just give you, this is some of my perspectives, looking in the data, trying to struggle with this in a couple different venues. I work at the residency program that's right near the hospital. So 50% commercial insurance, 25% Medicaid, 25% Medicare. But I also see patients at a federally qualified healthcare center in town that's 80% uninsured individuals. And so trying to figure out how we ferret through this and work with these individuals is sort of what this is hopefully going to help you sort of see where, at least right now, I've come to. I do write for narcotics at this point with patients. And have I changed some as the evidence has changed? Certainly, and hopefully we'll all do that. So with this, hopefully you'll be able to describe the role for primary care clinicians in treating chronic pain, describe some of the new guidelines that are out, and develop a plan for how you're going to approach this in your practice. How many folks are writing any narcotics for patients at this point? Okay, so some folks in the room. And again, I think that I'll start off with just a few cases, and these are real patients that I have. 92-year-old male who I've treated for years. He presented with low back pain. He's had a recent MRI. It showed degenerative disc disease, spinal stenosis L4, L5. He says he has difficulty being able to work in his yard, which he's enjoyed for years. He's got this huge garden that his wife had gotten planted. She died a few years ago, and he's trying to keep it up. He's tried acetaminophen, ibuprofen, naproxen, meloxicam. He said they do not help his pain. He's been to our spine center for physical therapy, which did not help. He's seen neurosurgery. They didn't have anything to offer. He has a medical history of hypertension, CHF with preserved EF, aortic stenosis, carpal tunnel. He's wondering if there's something we can do so he can occasionally work in his yard. Okay. So how many of y'all have a patient that sounds somewhat might be familiar? I mean, yeah, for a lot of us in primary care, folks just don't walk in with, I've just got back pain. And so then we're told, what comes up here is, he's got CHF. I shouldn't be using NSAIDs for him, right? We're told that. How much acetaminophen can he take at 92 years old? And so then we're sort of like, then we're trying to balance, okay, there's a quality of life at some point for this guy. He wants to work in his yard. How do we work through with him? We actually, with him, ended up trying 5 milligrams of oxycodone that he would use prior to going out and work in his yard, and he used about 8 or 10 of those in a month. And we felt like that was a reasonable option for him with what we were doing. But you can see also where I went through a lot of other things. That wasn't the first thing. When he first walked in the office, I just said, here's your prescription for narcotics. Have a good day. Second one, 49-year-old female, been seeing for years. This is at the FQHC. Presents for follow-up for a knee arthritis. She's been to see the orthopedist who says she needs a knee replacement. She's bone on bone. She's had her injections, hyaluronic acid, that didn't work. Her BMI is 49. At Wake right now, for most of our joint replacement surgeons, it's a BMI of 40. That's where your BMI needs to be. They're not going to do it because of things she's had. At the current time, she's on celecoxib and gabapentin, which she can afford. She was not able to, and we were not able to get her into the program to try pregabalin. She tried it before when she had insurance, said it didn't work, and then so that's what she's on right now. Otherwise, she's been doing well. She doesn't have any history of depression, doesn't drink or smoke, has had narcotics a couple times after surgery, did okay for that. How many of y'all for this patient would want to put her on narcotics? Good, yeah. You might think about it for an occasional type thing. The problem is, what does she have? She's got a chronic condition at a young age that we know we're going to get her stuck on narcotics. So there's a long-term discussion as far as can we get her to lose some weight. She ultimately, what does she need? she needs a joint replacement, right? And so trying to figure out how we ferret and work with her. I actually did try a little bit of Voltaren gel with her, and she actually felt that she was getting some relief and was able to temporize with that. The biggest problem is trying to get her to lose the weight, right? Because it's harder for her to exercise. She also has not been able to change her diet enough to lose weight. Third person, yeah, hopefully you'll see, this is at the FQHC as well, 34-year-old male. I've been seeing him for a while in the past. He's had chronic pain in his hand and his elbow. He's a lumberjack and works in lumbering up in Stokes County and would come down to the FQHC to see me. I hadn't seen him for a while, and he had been on hydrocodone in the past for some of his chronic pain issues. And when I checked the controlled substance registry to see what was going on, there was this break of about 6 to 9 months where he hadn't received anything. So usually that's a signal. If you look a little further down the case, you find out that, oh, yeah, that break was because he had gotten arrested. He had been selling his narcotics, some to make ends meet. He didn't obviously need them, and we hear that story, that happens, and so it does really happen, and it happens even to me when you try to be as best you can not to let it happen. And then, I started talking to him about, okay, well, clearly you've had a problem with hydrocodone. Clearly you're not on it right now. He said he had been out of prison for 2 months, and he's been making it, but he wants his hydrocodone, and so somehow or another he thought telling me that he was going to go out and buy it on the street was going to make me prescribe it for him. I tried to talk to him about what are some of the other options, even talking about, do you have a dependence on this, and do we need to get you in? I'm not Suboxone trained yet. I'm trying with all my other hats to get time to do that, and we're looking at doing it at the FQHC here in town, but he just didn't want to hear it. So he got angry and just left, and I haven't seen him since. Okay, and that will happen to some of us, and unfortunately, if you take that emotionally, what happens then? I'm never going to write another prescription of this, right? I'm not going to deal with these patients anymore. And it's very easy to internalize that. And I've seen it happen at our FQHC because we do see a number of patients like this that are dependent, and they're seeking it for reasons for dependence, not for something to treat a chronic pain issue. But then you have the patient that came in, I had one about a year ago, came in, and everybody said, oh, he's just drug seeking, right? He's a drug seeker. I said, well, let me talk to him. He's complaining of severe pain in the lumbar area. I said, we need to image him. He's never had an image down there. How many of y'all get a stat page from radiology? Not very often. I got a stat page from our radiology at Wake. We never get those. He had critical spinal stenosis. His spinal canal was about 5 millimeters in size, squeezing his cord down. And if he had fallen, he would have been paralyzed from the waist down. So that's the struggle particularly at the front lines in primary care, we face when we're dealing with patients, of not letting patients like this 34-year-old completely frustrate us. Okay. And then this last one, patient I had a little over a year ago that I was taking care of, and taking care of him for 12 years. 78-year-old male. He'd had melanoma diagnosed and removed about 8 years prior to this. Then he showed up and had a massive liver lesion, turned out to be metastatic melanoma. So he went into hospice, and he was having a significant amount of pain. We just weren't able to control. He wasn't able to just get it controlled, and just miserable. How many of y'all think it's appropriate to write narcotics for this gentleman? Yeah, so he was dying at that point, and so there was nothing that we were going to have that was going to make a difference for him at that point. He didn't end up, there's a balance, right, that we've got to talk with families and with the patients as well when they're coherent. You don't want to completely narc them up, as we call, or make them incoherent so that they're not able to interact with family, but how can we control? The likelihood that he's going to have long-term addiction, he had a lifespan of about a month is what he had left, and he actually died in about 2 weeks after going into hospice at home, but he was also able to die at home, which is one of his desires, with his daughters taking care of him, because we could keep him comfortable. So those are just some of the things, some of the patients, I think hopefully are reflective of some of the patients we all see as we're doing primary care. Why worry about this? 11% of the population right now currently deals with daily pain. Okay, 35 million people or so. 230 by 2030, estimates are 20% of the population will be 65 or older, and of that group, many of us at that point when we hit there will have some chronic pain. Roughly means 70 million people, if on the low end, would have chronic pain on a daily basis, and they'll need help managing their symptoms. And am I standing up here saying just give everybody narcotics? The answer is no. We need better options. We need to continue to work for those options. But will some of those patients end up ultimately possibly needing narcotics? The answer is probably yes, until we get a better way to treat pain. 50% of the elderly living in the community and 80% of the elderly that are institutionalized reported daily pain. 93% of them reported neurosensory type pain. How good are narcotics for treating that neuropathic type pain? Not at all, right? You have to use such high doses, so maybe we need to be thinking about other options. 68% had that neuropathic pain. Multimorbidity is common in this age group. That's not anything, this is just from the study, nothing that we don't already know. As we get older, patients come in without one problem. They come in with multiple problems that we're trying to manage. Why worry about this? An increase in opioid deaths have happened. 12.3 per 100,000 in 2010, 16.3 per 100,000 in 2015. Lest we forget that there are other things people can overdose on, benzodiazepines, other things, alcohol. We routinely every year when I do our inpatient services as well, we had a student from Wake Forest this year that decided somehow or another with depression and on fluoxetine, thought it would be a good idea to heavily consume alcohol they never consumed before, had over a fifth of alcohol in about an hour, and then decided it was a good idea to take someone else's Adderall, and thought then it might be fun to smoke a little marijuana on top of that, and came into the emergency room obtunded. Fortunately, his friends brought him, because who knows if they just laid him down to sleep, would he be woken up? So there are other things. 63% of these deaths, however, are related or involve an opioid. They may be a combination or just by themselves. Right now we've heard, and you'll hear there's more stuff coming on. China's denying that there's any fentanyl coming in from China. You've heard the reports that they're worried about this stuff. It's coming you can mail it in, so it's actually coming through the postal system now into the U.S., and they're trying to figure out how they stop that from being mailed in. But so this stuff is going to be coming in, so we do have to think about it, and are we going to prescribe something that will be the gateway or the starter to get somebody else to have to go out and start seeking heroin or fentanyl? Many of us have to make a decision. We're going to have to make a decision. Are we going to struggle through this period of time where we're trying to figure out how we treat patients, how we work with them, or are we just going to say, I'm never going to write narcotics? And I have colleagues in my department. I am chair, but that doesn't mean I'm king, so I don't get to pass an edict to say everyone must or everyone will. But I've got colleagues in my department who will never write this, and they just say, I'm not going to do it. There's colleagues in our network of physicians that I work with. My plea for those of you who just choose not to write it is not to tar and feather those of us who try to struggle with our patients in this. That does happen. I've had it happen to me where, oh, you're just the candy man type thing, right? Have any of you heard those comments, if you're in those practices? So I think we have to recognize that there are going to be some folks that are going to try to struggle with this. There are going to be others that don't. There certainly are physicians in North Carolina who have created pill mills, right? And I oftentimes hear about those. I do see some of their patients that come down from some of the surrounding counties that don't have much, and they end up coming to the FQHC when their clinics finally get shut down. And these are the clinics that are charging $150, $200 a month. They come in, you get your 120 oxycodone, there's no exam ever done, those type things. And this is just an example. I like this slide. It gives you some sense. This is North Carolina data, 913 deaths, 2,698 hospitalizations, 3,000 emergency room visits, 349,000 residents in North Carolina said they were misusing the prescriptions, okay, and 7 million prescriptions. So the reason I show this is, one, this is part of the problem, but two, if you look at that bottom line, to think that we are going to go to zero narcotic prescriptions when we've been writing 7 million, that's just not going to happen. So that's where I think understanding these guidelines are important. We are already, and it is a little bit scary, the next lecture is on NC Stop. NC Stop has passed. What's going to happen with NC Stop, and it scares me on the legislative medicine side of things, our legislators said we've got to do something to help protect the public. So NC Stop has been enacted. Opioid prescriptions are going down. They were already going down because of the evidence and the guidelines that are out there. But what are the legislators going to see? We passed a law, this changed. So now we need to pass more laws to legislate more what doctors need to do, right? And those of us who are involved in policy are concerned about that because there'll be a correlation, not necessarily a causation. So we're starting to see now, as I look in the literature, there are some editorials that are coming out where people are saying the pendulum has swung too far. We're not treating anybody and we're leaving people miserable and their quality of life is going down. We worked way too far over here. This is one of the studies that said we are under-treating the chronic pain in the elderly, particularly with cognitive problems, that when we treat them, then they seem to have a better quality of life. So let me run through the CDC guidelines. And this will be, unfortunately, I'll try to make it not too dry, but this is running through the points of the guidelines just so that we've seen them and we've heard them. For those of you who are in North Carolina, this is important because if you have any Medicaid patients and you happen to write for a certain dose of narcotics, there's a prior authorization that you have to fill out. We're doing this in our office where we have a pharmacy tech that fills it out for us, but she has to attest to the fact that we've reviewed the guidelines, which we're going to do here, that we're aware of what the medical board says, which we'll talk about here. And so we have to attest to those things that we're aware of these things, okay? So you'll see at each guideline there's a level that's sent in. It says A applies to all patients. B says there should be shared decision-making around the recommendation. And then, of course, there's always level of evidence, type 1, type 2, 3, and 4, okay? Type 3 and 4 evidence is what you're going to see the vast majority of, and the vast majority of it is type 4 evidence. So these recommendations are not borne out in randomized controlled clinical trials. We don't have long-term data proving that these are going to change things, but they are the CDC guidelines that are out. I won't go through there's another set of recommendations I've included in the slides, and we'll make sure you guys get them, that have, at the end, that are from this summer, from the Pain Society, that mimic almost exactly the guidelines from the CDC. So these things are becoming the guidelines we need to follow. So recommendation 1 is for non-pharmacologic therapy and non-opioid therapy are the preferred for chronic pain. So we should be trying those things first. We should not be just sort of with chronic pain patients writing for the narcotic right away. This can be a struggle because you have patients that come in, they've said, I've had chronic pain for years, nothing's working, they walk in and I want oxycodone. I have a friend, I took one of their pills, it felt good, I want that. They can get frustrated with you, but we've got to remember we need to try these other things first. We should only prescribe opioid therapy if we think the expected benefits for both pain and function are anticipated to outweigh the risks, okay, of that medicine. And the opioids are used, they should be combined with non-pharmacologic and non-opioid therapy as appropriate. So there are studies that came out back in the 90s that looked at this when we were ramping up our treatment of pain. We needed to treat more and more. People even back then felt like it might be a problem, that looked at celecoxib, that using Celebrex, combining that, you actually decrease the total dose of opioid that you need to use. Many folks don't use that. We've gotten away from the COX-2 inhibitors. They cause heart attacks, everything else. But there are some methodologies that we can use to decrease the overall amount of opioid if we need to go there that we end up having to use. Before starting opioid therapy for chronic pain, we need to establish treatment goals with all patients and goals for function and pain reduction. So what do you think most patients walking in when they're coming in for pain want? They want the pain to be, their score to be 0, right? That's just not realistic for most of the patients I see and not for most of the treatments that we have. So I talk to them about we're trying to improve function is the goal here, and we're trying to get your pain to a manageable level, but I'm not going to get you pain-free. To get you pain-free, you're going to sit around and just be non-functional, basically, for a lot of folks. There may be other methods that we can improve, but I don't set pain-free 0 as a goal because that just tends to set people up for frustration. You need to think about how you would discontinue it if the benefits don't outweigh the risks. So if they're not getting benefit from it, they're not improving. And you should continue opioid therapy only if meaningful improvement in pain and function that outweighs risk. So what's meaningful to one person may not be meaningful to another, but certainly for some people, meaningful drop in the pain score from 10 to 8, they may view that as meaningful, But part of what we need to look at as well is what are they able to do with that? Are they able to function better? Can they get out and play with their kids? Could they, for this older gentleman I had, could he go out and work in the yard? And the answer was yes. His family told me that. And he would come in being much happier that he was able to do some things. So improving that function. Before starting and periodically during therapy, you need to discuss with patients the known risks and benefits of opioid therapy and the responsibilities, your responsibilities for managing therapies. So a lot of folks want to do pain contracts. You know, they write everything out in these multi-page documents and that sort of stuff. The one thing I've seen with that, even in our own institution, we have a pain contract, people have the patient sign it, and then when they don't adhere to the pain contract, they just keep treating them. That doesn't make a whole lot of sense to me, that you either use the pain contract as a way to really say, this is what I'm doing, or don't use the pain contract and work with the patient and be clear. But having the pain contract and then just continuing to treat when they've broken that contract or not doing the things you need to do. I'm very upfront with patients right now, and I'm honest with them when I'm working with them. If I'm going to take you on as a patient and try to work with you, to some extent, the way I feel in North Carolina right now, it's putting my medical license at risk, right? How many of y'all feel that way now when we write narcotics? It's almost like, you know, you hear the North Carolina Medical Board, if a patient that I'm treating dies and that death is said it all to be related to opioids, I'm going to be reviewed by the medical board. Okay. Most of us would never be, and I'm certainly not going to be in the top 2%, but the top 2% of prescribers in North Carolina prescribing these narcotics will be reviewed automatically by the medical board. So we're getting this sort of stuff where it's almost like, and I'm up front with patients, I need you to do this. I'm not going to risk my medical license. And they seem to be okay with that. They understand that I'm just being honest with them, that this is where we sit. When starting opioid therapy for chronic pain, you should prescribe immediate release opioids instead of extended release. And this is something that, you know, if you've been around and doing this stuff, back in the early 2000s, there was a big push, right, that will decrease the addiction potential if we use long-acting because they're not popping pills. So everybody was getting on the OxyContin or MS-Contin and these long-acting things. We just thought it was better. Well, actually what they've shown is, and with this observational study, that's why it's still evidence for, is that if you look in this particular study, you had an increased risk of mortality, 64% increased risk of mortality if you started a patient on a long-acting opioid. Okay? And a long-acting, that also includes methadone. If you're using it for pain, is considered long-acting because it stays in your system so long. Interestingly enough, that was in the first 6 months of treatment. Okay, so within the first 6 months, if you put somebody on a long-acting opioid, you increase their risk of mortality. If they were a chronic pain patient and they were being treated in this chronic pain center, longer term, after they'd been on a short-acting, if they then added a long-acting, they didn't see that same increased risk. Interesting, it may just be you get too much of a dose, it's in your system longer, and are you combining it with other substances? Not clear, but I think we definitely should not be writing any of the long-acting if that's what we're going to start somebody on. We certainly shouldn't be for acute pain, and I would say not even for starting chronic pain treatment. When opioids are started, clinicians should prescribe the lowest effective dose. Sort of makes sense. I think that's the same thing we do for blood pressure. We don't write for 3 times the amount of insulin that you need. You know, we're going to create problems. The same thing with this. We should look for the lowest effective dose for the individuals. There's a lot of data coming out now that actually, if we get people on too high of a dose, we actually can, the narcotics, much the same way we think about overtaking Tylenol to treat headaches, getting rebound headaches, using too much narcotics, you actually can sensitize and you actually increase their pain. So they get a counter response. Doesn't happen to everybody, but for a small percentage of patients, they'll get this response. So as you increase their narcotic, their pain gets worse. And if you just keep increasing it, it's because actually they're responding to the narcotic. And this is the other thing that's come out that I think is extremely helpful, that I think most of us are going to be held to if we're writing for narcotics, is these recommended morphine equivalent doses. Okay? So if we're writing it, it's recommended that we need to consider the risk as we increase the dose greater than 50 morphine milligram equivalents per day. Okay? So if morphine is 1, for hydrocodone is 1 to 1. Okay, so if I'm doing 40 milligrams of hydrocodone, they're getting 40 morphine equivalents a day. Oxycodone is 1.5. Okay, so if I'm doing 40, they're getting 60 morphine equivalents. Does that make sense? And so there's strong evidence right now that low dose narcotics are considered 50 or less of milligrams of morphine a day, 50 milligrams or less. High dose is 100 milligrams of morphine or equivalents a day or more. And you increase the risk of side effects and increase the complications goes up 8-fold when you go above 100 morphine equivalents, 8 times the increased risk. Okay? So we certainly want to try to keep these dosages that we're using down below 50 morphine equivalents. There's tables out there if you end up using, if you had somebody that came to you and they're on Dilaudid and you're trying to figure out what's 8 milligrams of Dilaudid, I just pull it up. Those are things that we used to have to always try to memorize because it's too hard to go out and find it in a book. Now I just pull it up. I've got an app that's just a morphine equivalent calculator. It's very simple, quick to plug it in. The sixth thing that they have, long-term opioid use often begins with treatment with acute pain. So if you talk to most of the pain specialists at our shop and at Wake, we sort of said, acute pain, you roll into sort of the chronic pain treatment after 3 months. Okay, so that acute pain should be gone for most things, most surgeries. I happen to have, my wife doesn't mind me sharing, she had to have knee replacements, and some of the stuff that we've got, some of the things we're going to hear about NC Stop where you can only write for 7 days of a pain medicine after a knee replacement, I can tell you that was not going to be enough for her at this point. But what can happen, and we have to be careful of, is that can transition. How does that happen? They've been seeing their orthopedist, back surgeon, you name it. They were getting their prescription from them. They've been getting it, and then all of a sudden, now they come up on your doorstep saying, I need to get it. It's a busy day. You kind of write the prescription for another month, and then they come back to see you, and all of a sudden now you're kind of gotten in this pattern. They call in, somebody refills it for you because you're on vacation. So we do need to be very careful about this transition between acute and chronic treatment and understanding that it often starts, for a lot of folks, the problems can start with the acute pain treatment. We need to evaluate the risk and harms within 1 to 4 weeks of starting opioid therapy for chronic pain or of dose escalation. Okay? So in North Carolina, right, we've been able to write 3 monthly prescriptions if we're still handwriting them. You can write 3 monthly prescriptions and write a fill after date on them, and that's appropriate if you want to do that. It's under the guidelines of the pharmacy board and the medical board. We shouldn't be doing that right out of the chute. We need to have people, and we need to have them back in. And so my patients, if I have to get to a place where I'm going to start this on in somebody, I have them back in a month to see how things are going. I don't give them 3 or 4 months at a time before if I don't understand, is this really going to work or not? Why? Because if it's not working, what's one of the problems that's going to happen? They're going to divert the medicine, right? Believe me, a lot of the folks particularly the folks I see at the FQHC who are economically challenged, the people who are around them, if they hear that they've got this, they'll start offering, let me buy some from you. I know somebody that'll buy some from you. This stuff is happening to some extent, so we do need to be careful with that. We have in our building at the residency program, because we do have patients that are on this, we actually now have a medicine disposal, kind of like a UPS box, metal box, so that we're telling people, bring it in, put it in there, if you're going to do that. But we do want to be careful not to just send them out and not assess what's going on with them. This is one of the assessment tools, and there's a link in the references that goes to CCN, Community Care North Carolina, put together a thing called the LAZARUS Project. Got started up, it was piloted up in Wilkes County. There was a problem with people dying of opioids, and so one of the things out of the LAZARUS Project was the Narcan pens for family members so that they could administer. But they also gave a whole set of tools, and this is one of their tools of a pain assessment. So if we have somebody that we're treating, have them come in, they can fill this out. What's my pain like now after you started me? What activities of daily living can I do? Are there any other things going on that may say I'm at risk for diverting or I'm abusing this or becoming addicted to it? So you want to take a look. These things, and it's called the LAZARUS Project. If you just Google that, it's available. I checked online just 2 days ago to make sure the link was still available, and it is. Recommendation 8, before starting and periodically during the opioid therapy, you need to evaluate risk factors for opioid-related harms. So what do I mean by this? Are they coming in, or their family members telling you, that, they're too drowsy? You're noticing when they're coming in the office, they look disheveled, where before they were coming in looking okay. So are they transitioning to the other side of being more addicted to it? Are they not showering? Are they, checking and finding out the registry, are they now getting benzodiazepines from someone else that you didn't know about, and those things are happening? And also checking the registry to find out, are they getting medicines from another physician, okay, care provider? So doing those things, we want to check and make sure, are there any harms that we're going to create for that patient? And that's no different than we would do if we're starting an ACE inhibitor. We're supposed to check a creatinine to make sure we're not putting them into renal failure, right? It's rare, but it does happen. And so we need to be checking those things. Same thing with this. Here's one of the studies looking at 2016 published, looking at some of the risk factors. So the overall risk in this particular study for folks that to abuse the medicine when we wrote it was 0.3%, okay? So when I asked the medical students, and this is sort of what's happening, with my kids when they were going through school, and they're now 20, when they would come home, if I had a beer on the weekend, it's like, oh my God, Dad, that's a drug. You're going to be addicted, that sort of stuff. So our medical students, when I ask them in the clinic, if I have a patient who I'm writing a prescription for, they come in and I'll say, what's the risk of addiction when I'm writing this prescription for the patient? And they'll go, 30, 40%. I was like, no, that's nowhere near that high. What's the number needed to treat? If you do in a study looking, number needed to treat to reduce the pain score by half. So to go from 10 to 5 or 8 to 4. Number needed to treat is 2. Okay. Significant problems with these medicines. I wish we had better medicines, but we can help people with their pain. But that means one person we're treating, we're not helping. We need to get them off the stuff. Another person we may be helping, but we may be running into harms as well with them. So we just need to be aware of that. Certainly younger individuals, I am completely convinced, and my psychiatric colleagues and neurology colleagues may be able to shed more light on this. I am seeing a group of folks now who are in their 40s and 50s. They're coming in with all kinds of chronic pain syndromes, aches, other things, and I'll ask them one simple question. Did you abuse substances in your between 20 and 25? And almost 100% of them say yes. And it's something like it rewires their brain, I think, to some extent. We were talking about the receptors earlier, but I think it almost, at that younger age, as we're learning with the brain development, I think we're almost seeing a group. And I've got several of these individuals that I've had to try to work with, and fortunately been able to get them into my psychiatric colleagues, who some of them, they've said, need to be on Suboxone because that's just where their brain has gotten wired. If they have a history of mental illness, okay, so those folks that come in, not that any of us have those bipolar, borderline, depressed patients in our practice, but if they're coming in with that, that's going to make their pain worse. Their pain may not get better, their perception, and we just increasing the escalating dose, which increases the harm. So we do need to be careful with those individuals. Doesn't mean we don't need to try to treat them and work with them, but just recognize 3 times the risk of addiction. If they've abused other substances, if they've had problems with benzodiazepines, if they've had alcohol abuse, increased risk as well. And the higher the dose, so the higher the dose, it just increases the risk of addiction and abuse for them. And then male gender slightly increases that. So that's just a list of some of the things. I think the biggest take home here is that higher doses, younger individuals, and a history of substance abuse, those folks, I just tell them it's not worth the risk. I mean, to me, and I refer them sometimes to a pain clinic, and sometimes they may decide to write them if they really need it, but they'll only give them a weekly supply, and they have to come back every week to make sure they're not overusing. I don't have time to do that in my practice as a family doc. The elderly. So we have the elderly. What do we know about the elderly? Well, in the elderly in this study, what they did with this study is trying to look at misuse of who's shopping around. How many people shopped around to try to get more of the medicine from other folks? About 0.18% in this study. It was 0.07% for opioids and 0.1% for benzodiazepines of people shopping around for this. Overall, about 0.12% will abuse or divert in a second study when you're looking at the elderly. Okay, so again, probably the fact that younger individuals, if you're 20 years old, you're hanging out probably not with 9-year-olds. You're hanging out with 20-year-olds. Younger individuals like to experiment. Okay, and so they go through things, and so you're likely to see them use this. Okay, so that's sort of one of the things we want to just remember and look at. Elderly are not as likely to misuse. You need to review the history in the prescribing registry. Hopefully all your states, if anybody's not here from North Carolina, you have this. Right now in North Carolina, just to be aware, we are required now to sign up for the registry. It's part of the medical board that we're supposed to sign in and have a sign up for that. We don't have to use it if we're not going to prescribe controlled substances, but we need to sign up for it. And we need to, when prescribing, we should use urine drug testing before starting opioid therapy and consider at least annually to assess, for other substances, okay? A lot of folks use this to try to say, well, they're not taking their medicine. But if I'm writing them a medicine to take, 1 tablet a day as needed, and so they didn't need it for the past few days, and it's not going to be in the urine. What I'm more concerned about is, are they mixing substances? So that person that now has THC in their urine, and they've got some benzodiazepines that I didn't prescribe, that tells me they're buying stuff from somewhere. And in North Carolina, marijuana is not medical at this point, and so those are the folks I have conversations with. And so that's how I use it. It is recommended that we look at it annually and recommend that we're doing it before. This is something that it was not clear to me that we at the FQHC, we didn't have a standard policy. Now we do that. If we're going to start anybody, if we're writing a narcotic for them, we go ahead and do a urine drug screen. We can do it right there. It is a screen, not a confirmatory test, but we can do the screen in the office for about $10. I mean, these things are inexpensive to do that. And then we need to avoid prescribing pain medicine and benzodiazepines whenever possible. Okay, that I think is huge. If you look at particularly the combination of alprazolam and methadone, huge increased risk, and where you start looking at this combined risk, partly the methadone stays in your system for a lot longer time than you're throwing alprazolam on top, just increased risk. And so we should not be, and honestly what I'm doing with most of my patients is talking to them about what's more important to you at this point. Is your anxiety causing you more problems or your pain? Let's figure out which one we're going to try to treat, because sometimes the anxiety may be making the pain worse, or the pain may be making the anxiety worse. Let's try to figure out if we can treat one and get you improved. And most of my patients have been receptive to that. And when I tell them, my concern is this stuff can stop you breathing at night, then they start going, oh, yeah, I may not want that. And I'm thinking, that's a good decision making. And then we need to arrange for treatment, usually medical-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opioid use disorder. Okay? And that's a category 2. If you go back through all these slides, almost everything is a 3 or 4. So it's great to have the first lecture on MAT. For us now to look at this as one of the last recommendations, if we're treating a patient and we feel like they now have opioid use disorder, typically what I see happen is, you're out of my practice. I'm done. I'm not writing this anymore. They don't even write a tapering dose. They just say, I'm not writing you anymore. So you're definitely forcing an individual into withdrawal, right? Because now they don't have time to find anybody else. You're not trying to set up any type of other therapy for them. So it is something where this is evidence-based that it does work for individuals, and if we think that's what they've got, we should refer on. Okay? If we decide to start, we need to think about these things, look at medical comorbidities, benzodiazepines, problematic alcohol use, and psychiatric things. Those are the things I look at and I worry about if I'm really thinking I need to start something on somebody. And then I just want to make sure misuse and abuse, or use disorder. Opioid misuse is using the prescription for something in amounts or routes other than what I prescribed. So the patient comes in and they've taken more of it than I prescribed. I said, it was twice a day. Well, doc, I was really hurting, so I started taking it 3 times a day. That's misusing the prescription from where I prescribed. And I tell them I'm concerned about that because of the risks of the medicine and when I'm writing it for them. That's misuse. Disorder, or what we might call addiction to it and that sort of stuff, is they've lost control. There's a compulsivity. As we heard earlier, they're getting up in the morning thinking about where I'm going to get this. They're going out and buying some of it off the street. You'll hear patients sometimes, at least as a family doctor, sometimes they'll tell me that. They just kind of start opening up. I'm kind of like, that's not good, that you're going and buying extra. And they will continue to use it despite adverse consequences. So this other gentleman who still wants his hydrocodone, even though he's already been arrested and put in jail, that would be an opioid. That's a sign of opioid use disorder, right, with that. And misuse, we don't dismiss them from the practice or discontinue prescribing. You need to document the misuse in the chart, discuss behavior change, and if misuse continues, then that's probably a sign that they're having a use disorder or an abuse or addiction to it. I'm not going to walk through these. I just wanted to include these in there. They'll be with the slides. This is from the American Society of Interventional Pain Physicians. That's their guidelines that came out this summer. there's more of them. They've broken them down to like 26. They mimic almost exactly the CDC guidelines. So everybody seems to be building off of the CDC guidelines. And then, I'm going to skip through there. I know you're going to have a whole lecture from a lawyer on NC Stop. That's our law. I mean, again, interesting sort of that whole thing, stop, sort of stop prescribing all opioids. That's not sort of where we want to be. I think the big thing, how many APPs do we have in the group? I know I see a couple that I know, so okay. Yeah, so for the APPs, one of the things with this, it's going to be interesting to see, even in our own practice. I've got an APP that has one or two patients. I mean, and in my practice, I'll tell you, I've got 1,100 patients that I have in my panel. That's too many for what I do as chair and other stuff. I've got about 20 people that are on chronic pain medicines, okay? So it's not, I don't have 300, it's not 30%, but I do struggle even with those 20 to make sure I'm doing what I should be doing for those individuals. For our APPs, you have to consult with a supervising physician if the treatment's going to exceed 30 days, okay, with this. And you're required to consult with a supervising physician at least every 90 days for chronic pain patients. So that means for Scott, the PA I work with, we somehow or another have to figure this out. So how we're going to do this. We're not going to be able to prescribe more than 5 days of a Schedule 2 or 3 opioid narcotic upon initial consultation or treatment of a patient for acute pain. Now these are acute pain things. Doesn't talk about chronic, but acute pain. No more than 5 days. So what is that going to mean? That's going to mean for the individuals that have a fracture that show up in the emergency room, the guy that's got a boxer's fracture and his hand's hurting him, 5 days when he's still hurting, guess what? I'm going to need to make sure in the office I've got capacity to bring them in, okay? So we're going to have to figure out what we do with these folks that may have been used to getting a little bit more of their pain medicine. 2 weeks, we can't do that. And then if they have an operative procedure, that it cannot exceed 7 days. So my surgical colleagues, particularly the ones that do some major surgeries, are really trying how to figure this out. There are some folks that 7 days will be fine for certain things, but there are other things that's not going to cut it. If you have a cabbage and they just split your sternum, you may end up, not all the time, but you may end up needing a little bit more, particularly if you're using a low dose. So we'll see how that goes. And then if they come back to see us, we can then decide we're going to extend the treatment for whatever time we deem appropriate. But it is going to put, again, the idea behind this is sort of, let's limit it, let's reassess, and then decide, do we need to extend it? Again, why? Because of all the pills that end up sitting in the cabinets. When I occasionally do home visits, not a lot, but I do have some. If you go in, the number of medicines that they're no longer on, that sort of, it's like they're hoarded away for some reason. I'm like, you're not taking this anymore. That sort of stuff can happen, and so we don't want that to happen for them. And prior to scheduling a 2 or 3, we're going to be required to review the 12-month prescription history in the North Carolina registry. This one, I'm not sure when this goes into effect. They're trying to update the technology, because if you tried to sign on, it's like 5 clicks to finally get to where you can enter a name and that sort of stuff, and it takes a little bit of time. And then before we write it the first time, and then every 3 months afterwards. This was going to be for every controlled substance. So it was going to be for benzos, for Adderall, for everything, every patient. We're going to have to do this on everybody all the time. We don't have to do it. It's just for the opioids at this point. And we need to review and document in the medical record that we've reviewed this. I review this, but I don't document it all the time. I figure, I don't understand why I need to document it, because the system knew I logged on that day, right? So why do I have to retype it that I logged on? But that's what they're asking for, and the medical board will want to see in our records. And then this is the medical board position. So if your license is under the auspices of the North Carolina Medical Board, they believe, this is their position statement for 2017, that a good component of good medical practice is evaluation and management of pain. Responsibly prescribed opioid medications may help North Carolina licensees treat their patients' pain safely and effectively and improve their quality of life. So just be aware, that's the position statement as of 2017. It does not say we should never, but it says appropriately, and if we've done an evaluation management, that there may be a place for these things. The board, we used to have different position statements. They were trying to come out with different things. What they have decided now in North Carolina is they're going to follow the CDC guidelines. So those 12 guidelines I went through, that's what our medical board is going to hold us to. They are not trying to create their own set of guidelines. So just for those of us who practice in North Carolina, be aware of that as well. And I have a feeling a lot of other states are going to move in that direction as well. Since we have a national guideline, let's just use that. So I'm going to stop there, I think. There are, in the back of the slides as well, I usually include some cases just for you to look through. There's low back pain, osteoarthritis, neuropathic pain, fibromyalgia, and then you'll see the references as Project Lazarus that's there. So I will stop, and I think I have a few minutes for questions. Okay, 10 minutes for questions, and then, or you can get a little bit of longer break to walk around so you don't get a DVT either. So I'll try to answer questions. And again, this for me is, I am not a pain specialist. I send patients to the pain specialist as well, particularly when I'm looking at would a spinal stimulator help for neuropathic pain, that sort of stuff. But I am in the place where I do have patients that I am treating chronically with narcotics and trying to find my pathway through this over the years of living through, well, just write enough pain medicine for everybody to now we need to be doing it a little more cautiously. Yes?
Can you hide that slide on sleep apnea? You said they were risk factors with opioid use?
Yeah, sleep. So if you have, particularly if you could think almost of any respiratory illness, but sleep apnea, COPD will increase the risk when you're using narcotics just from respiratory suppression. So if you suppress somebody a little bit, and if you think about the folks for our COPD patients, they don't have as much oxygen drive. It's more, their CO2 drive is gone. And so if you slow them down too much, and that's an increased risk. So they are recommending, we really need to have a good reason to use these medicines in that group. So particularly a lot of folks that have sleep apnea, not all, but a lot of them are overweight as well. So you have the obesity, and then you have the COPD, and throwing that in. And if you mix that with the huge risk is then you throw a benzodiazepine on top of that for that group. That group is at high risk for dying in their sleep. Yes?
How many patients do you see are managing with adult attention deficit and anxiety, wanting a stimulant and a benzo?
Yeah. How many folks am I seeing with that?
Or your experience?
Yeah. No, but I see folks that walk in saying that, and when you get into the adult ADHD, it can be quite difficult, right? Because they can go online, they know what symptoms to write. So if you hand them a symptom sheet for some of the folks that really want that, they're coming in. Certainly, I have some folks that, in concert with psychiatry, who they end up, because of some of the medicines they need to deal with whatever their mental health issues are, they're so sedating that they end up on one of the stimulants as well to try to boost them up from that standpoint. I don't worry as much about those two together. I don't write a lot of those two together. That's just me without a consultation with psychiatry to sort of say, is this appropriate or not? I have a fair number of folks that have what I perceive to be attention deficit disorder in adults. What I talk to folks about, my faculty sometimes accuse me of having ADHD because I like doing so many different things. So it's not just going everywhere. It's also being, is it impacting their lives? So I've got one gentleman who has had 4 marriages, changes jobs every couple of years. You start talking to him about his ability to attend. And so for him, and oftentimes I'll start with adults. I'll start with atomoxetine. So I actually start with something that's longer acting because for adults, we actually tend to work longer days, right? We're not just in school till 3. So I'll start with atomoxetine, not a stimulant to start with those individuals. And then with anxiety, if they're coming in, if they're having problems, if they have severe anxiety and they're saying they have ADHD, I usually will talk to them and say, you got to get the anxiety under control because anxiety and depression impacts your ability to concentrate, right? I mean, if you're sitting around being anxious all the time, and you're focusing on your anxiety, I don't know how you attend to the task at hand. So that's sort of my approach to it. If I think they need both, I actually ask psychiatry to see them. And that's hard. I'll tell you, at Wake, we're trying to find our pathway through telepsych and how we actually how can we get consultations without always having to send patients to our psychiatric colleagues because that's hard. Any other questions on this? Great. Yes. Mm-hmm. Yeah. So the question I'll repeat, just make sure everybody on this side could hear, is do we need to be using a pain contract, and are we going to get in trouble if we're not using a pain contract on every patient? And the comment was that particularly somebody that's 85, do I necessarily go through a pain contract and that sort of stuff with them? And in all honesty, the answer is no. I will tell you that we as clinicians trying to thumball who's going to come in and who's going to end up being the person who's going to get addicted or misuse, we're horrible at predicting. That's why in my clinic at the FQHC, they were wanting to select who they would do urine drug screens on. And I was like, oh, no. I mean, there are people who are functional, right? But who are also still using benzodiazepines off the street or using some marijuana while they're taking their pain medicine as well. So I do standardize that I've just sort of put that in place, that we do that on everybody. And I just let people know, I'm sorry, I don't want to be in the stereotypical thing. This is me personally. If the medical board's listening, I guess they'll have to come and tell me if I'm not up to snuff. I don't tend to use, I had a discussion around the use, that sort of stuff. Having people sign things, just the same thing, I still do deliveries. Having them sign that they don't want a quad screen to rule out Down syndrome, I think it's much better for the patient, provider relationship, for me just to document that I had that discussion rather than, because they don't read the whole thing. I mean, they just don't. So I go through, don't take more, you need to come see me, I've got to see you period. If you're missing your appointments, I can't keep writing it. We'll do the urine drug screen. I talk through that with them, and then we review it. Yes?
The only thing I'd say, I have an 85-year-old grandmother
Yep.
that's diverted.
Yep.
I think the grandkids are taking the medicine.
Yep.
You can't know.
Right. That's what I'm saying. Yeah, that's why I when you walk through, I mean, I don't know if it's urban legend or not, but supposedly up in Wilkes County, there was a group of women who were getting together for Bible study who were diverting some of their medicine. So, I mean, again, if folks, and some of it is well-meaning, my so-and-so didn't have insurance, didn't have access, they sprained their ankle, I've got some medicine, I want to just try to help them out. I don't think they're doing, but some of them are doing it for money. I don't have money, I can't get food, somebody else is willing to buy these tablets for me. That's what I said. I have not been able to predict. You'll be in groups where when you talk about medical assisted therapy, and you talk about maybe you guys could think about doing it, it's like, well, we don't want those patients in our clinic. And those patients are everybody. We have those patients. They're everywhere, and it's not just, I think sometimes people think folks that get into trouble with these medicines they're tattooed up, the tear tattoo, and all this stuff, and multiple piercings. But it's any of us that could use the medicine. My wife was concerned that she needed it, but she was concerned of, keep a watch on me to make sure, I'm not overusing it, that sort of stuff, because we just don't know, because both she and I have some alcoholism in our families, we have some mental health in our families, and so, there was concern there. So, you cannot, if we start trying to do this, I think, number one, we bring our own stereotypical biases into that, implicit, unrecognized, whatever, but we're bringing that into the way we treat patients.
I think that those people you don't expect that surprise you.
Yeah.
The tattoo, they tell you the truth.
Yeah. They're more, as people say, they're more real. It's the business person or somebody else that's just trying to hide it. They feel like they need to hide it. Yes.
You were in a family practice.
Mm-hmm.
You said people, how do you handle it when somebody else in your practice prescribes totally differently? And you're on vacation, like you said.
Yep.
You have to write a prescription that's not what you would prescribe. I mean, I worry about like the medical board looking at something that I have to write for a partner that's not there today.
Right.
It's not a prescription I would have written.
Yeah, I think.
We have to cover for each other.
Right. I think we have to cover for each other. I think it has to be within reason. So the question was, what do you do with partners if I'm writing for 2,000 oxycodone in a month for a patient, should you really have to write for that? And the answer is no. I mean, what sometimes happens in our department, when I'm gone, I have folks in my module. We have 4 modules, and they'll oftentimes go ahead and prescribe that. And I've also worked with my physician assistant, so we talk about if I'm going to be gone. A couple things I have the benefit now of electronic prescribing, so I can do it from wherever I'm at, good, bad, sometimes I'm on vacation. But also, you don't have to, oftentimes if they were not sure about it, they would just write it for a week's supply. I'm going to be back, and then go through that. And the medical board, I think sometimes we think about the medical board jumping on us for doing something. If you put the patient into withdrawal, and they write you up to the medical board, which is very easy to do now. I don't know if you guys have been to the medical board website. There's a big green button file a complaint. I mean, it's like the biggest thing on the thing. And so and I'm dealing with young physicians who are getting complaints that it's devastating them. They're getting complaints for ridiculous type stuff that because we've got this big green button. So I think it goes both ways. Now, on the flip side of that, we've had patients come into our department, and they've come in on regimens. One patient came in on 100 microgram fentanyl patch every 3 days, was getting 8 milligrams of Dilaudid 3 times a day for breakthrough pain, and was getting a prescription for oxycodone. I think it was 4 times a day. I mean, I don't know how the person was still walking around. That we just had the discussion with the patient. We're going to work with you on getting you down off of that. At some point, the stuff's just floating around. There can't be any more receptors for it to attach to. I mean, you've taken care of all of them, and so you have to sort of work down. And we should feel comfortable doing that. And I found, I'll give another example in our practice. Sometimes, because we have young physicians, they'll go in and they're going in with, I'm never going to write this stuff. We have folks that come down from Boston or other areas, and they're just, I'm not going to. That's just sort of, it's maybe a perceived bigger problem. I think it's just a bigger problem here in North Carolina. It's just in the more rural areas here. And they're saying, I'm not going to write it. And the patient comes in, and the patient clearly has a need for it. I'm not going to do it. Well, then the patient gets angry because they've been getting it for a time. This was a patient that was handed off from a graduating resident and so then you come in and you start talking to them, and you can work through things with them. So I think it's that idea of we need to care for the patient. And even patients, most of the time, I've had other patients said, I just can't write. I had one the other week that really wanted pain medicine. I said, I don't see that you have a reason to be on long-term narcotics. Let's try other things to treat your pain. And she was fine with that. And that's what I find most of the time. I just don't focus on the people that get angry with me. I just can't. So, yeah. All right. So hopefully this was helpful, at least to think through some of these things, at least to review the guidelines. And now I think you're going to get to hear from a lawyer eventually, right? On NC Stop, which will be really good to hear what's going on in our state to kind of remind us what we need to be doing. So thank y'all.